So welcome everyone. So glad to have you here today. I'm always excited when I look at the list of attendees and recognize that I don't know everybody. So my name is Elena Dinkin and I oversee the senior adult program here for the YMCA. It's been a wonderful ride partnership to work with UT Health Houston and Elise Pratt. And we're so lucky to have that sponsorship for a monthly doc talk from the comforts of your own home and to enable all of you who live in different parts of the greater Houston area to benefit and to learn. I know that today was a big hit for the topic because I saw quickly registration for and a large number. And those of you who are on the call, please note that I will be sending out a recording if you can't remember something that was said or you want to look back over some notes that was pointed out. So at this time, I ask Elise Pratt to introduce our presenters for today. Thank you, Elise.
Thank you. So yes, we have two presenters today to talk about sleep and getting better sleep. They are both from our organization, UT Health Houston, and they're actually from different departments. So Dr. Verma is a sleep medicine specialist and neurologist from UT Health Houston Neurosciences, and Dr. Gomez is an ENT doctor from the Department of Otorhinolaryngology, which is the long word for ear, nose, throat. And they're going to talk to you today about sleep. Any questions that you have, you can put them in the chat window, as Elena said, and we will get to all of those at the end. Dr. Verma, I'll let you get started. And Dr. Gomez, I think you were going to share your screen.
Yes, let me go ahead and do that right now and put it on. It should be coming to, there you go.
Perfect. Thanks for that introduction, Elise. I appreciate that. The goal of the talk today is to go over the traditional treatment options for sleep apnea. First of all, talk about the most common sleep apnea that we refer to, which is obstructive sleep apnea. And more importantly, focus on the newer treatment options that are available to patients. Next slide, please. So the scope of the problem is rather broad. There are 20 million Americans that have significant issues and are diagnosed of moderate to severe obstructive sleep apnea. It's important to recognize this because it not only disrupts the quality of sleep, but decreases the quality of life and contributes to multiple medical problems. There's a lot of misconceptions, lack of adequate information on some of the newer treatment options that are available. So myself and Dr. Gomez, we are here to go over the issue, talk about the traditional treatment options, focus on the newer options, but also take any of your questions that you all might have at the end of the talk. Next slide, please. So the objectives are to define the problem, talk a little bit about the risk factors, possible causative reasons for these issues for sleep apnea, and focus on the treatment options. Next slide. So what is sleep apnea, and more importantly, what is obstructive sleep apnea? The most common form of sleep apnea is obstructive sleep apnea, where patients are experiencing recurrent episodes where their breathing stops and restarts. And this happens several times throughout the night while someone is asleep. The most common form of sleep apnea is obstructive sleep apnea, like I've mentioned. There are also other less common forms like central sleep apnea and mixed. And the mixed sleep apnea now is recently coined a different term called complex sleep apnea. Next slide. So obstructive sleep apnea it's a chronic medical condition which causes recurrent obstructions or restrictions in the airflow where the throat muscles are collapsing periodically throughout the night. One of the ways to diagnose this is a diagnostic sleep study, which we'll talk about that in the next few slides. Next slide. As you can see, the imaging study picture here on this slide, which shows a normal adult pharyngeal airway, which is nice and open compared to the one next to that, which shows that there is a significant blockage in the pharyngeal airway, causing narrowing in the airway, restriction of the airflow, and thus loss of oxygen that happens during episodes of restricted airflow. Next slide. So patients with sleep disordered breathing, that's another common term that is used for obstructive sleep apnea, can fall in a big spectrum. The symptoms can start with symptoms of snoring, then it progresses to a stage called upper airway resistance that can lead to sleep apnea as well as hypoventilation, where not only there is restriction in the airflow, but this exhalation of CO2 can also be restricted in certain patients. Next slide. So the other less common form of sleep apnea is the central sleep apnea, where the brain is not sending adequate signals to the respiratory muscles to breathe. So despite of not having any obstruction or restriction in the airflow, the respiratory centers are not getting the drive, and thus the patient is not breathing well or optimally while asleep. Next slide. So we will focus the talk mainly on obstructive sleep apnea, the risk factors and the treatment options. So what are the common risk factors that we encounter for patients that have obstructive sleep apnea? Being overweight definitely adds to the problem. However, age, as we age, that is one of the most important risk factors that can increase the prevalence of obstructive sleep apnea. Upper airway anatomy, where if patients are having small chin, large tongue, and large tonsils or adenoids, can cause to the crowding of the upper airway and can contribute to the symptoms of obstructive sleep apnea. Next slide. So what do people or patients usually present with? It can, again, the symptoms are also spread out on a spectrum. Patients can present with fatigue, unintentional sleep episodes, excessive daytime somnolence, or sleepiness despite allocating adequate hours of sleep. They can also have symptoms of snoring, history of stopping to breathe, gasping, choking while asleep. And in combination with the symptoms, the signs of obesity and or increased neck circumference can definitely add to the suspicion of possible obstructive sleep apnea. Next slide. So when a patient presents with these symptoms in combination, I wanted to point out the obvious physical signs like neck circumference. It has been established that increased neck circumference with more than 17 inches in males and 16 inches of neck circumference in females has a high association with obstructive sleep apnea. In advanced cases where sleep apnea has been misdiagnosed, obstructive sleep apnea has been misdiagnosed or undiagnosed, patients can also present with signs of heart failure, cognitive slowing, or early onset, dementias or other neurological disorders that obstructive sleep apnea can contribute to. Next slide. So what is the best way to diagnose? If someone has the symptoms and they have other signs pointing towards the diagnosis, how do we proceed with that? Nocturnal polysomnography is the nocturnal sleep study. So in-lab sleep study is the most comprehensive, most reliable way to diagnose sleep apnea. There are several different modalities, screening modalities like home sleep tests that are available. But home sleep tests are approved and are good diagnostic studies in patients that have classic symptoms of moderate or severe obstructive sleep apnea. So I always tell my patients that home sleep tests are good to rule in the diagnosis if you already have classic symptoms. However, if you're trying to rule out the diagnosis of obstructive sleep apnea, always, in-lab sleep studies are more reliable, more comprehensive. Having said that, the limiting factor usually is the insurance approvals, and some insurance companies have a built-in policy that most patients will have to initially go through a home sleep test in order for them to get approval for an in-lab sleep study later on. Next slide. So this is how a sleep apnea episode will look like on a sleep study. So what you're seeing on the slide is a 30-second compressed view. So there are like 4 30-second views that you would see on a study, where the red circle point towards decreased airflow near obstruction of airflow, despite having respiratory effort in the thorax and abdominal channels, where it is listed as THO and abdominal channels. So as you can see that as the event is going without any airflow, the oxygen saturation, you can see that it starts out at 96 and can go down to 92. And there are certain patients, depending on the severity of the sleep apnea, the oxygen levels can dip down to the 50s and 60s, even with severe sleep apnea. Next slide. So having talked a little bit about the presenting symptoms, the signs, as when do you seek medical attention, and when is it appropriate to see the physician? Obviously, if you're having symptoms of loud disruptive snoring, history of a bed partner or someone mentioning that they have seen that you're not breathing well or pausing in your breathing while asleep, or if you're encountering symptoms of daytime fatigue, sleepiness, or difficult to control medical problems, that is the time it is important to seek medical attention. Next slide. So we talked about what are the features that are commonly seen on a history, on a physical exam, touched upon a little bit about the home sleep test and an in-lab sleep study to arrive at the diagnosis. Next slide. Why is it important to diagnose and seek treatment for obstructive sleep apnea? Because it has an impact on many different treatable chronic medical conditions like hypertension, heart disease, stroke, and it also increases the risk of cognitive disorders like cognitive impairment, as well as dementia. Next slide. So obstructive sleep apnea is identified as an independent risk factor for increasing the risk of cardiovascular and neurological issues by both American Heart and American Stroke Association since 2007. And if you're seeing rather a young, otherwise healthy person that developed hypertension and that is treatment resistant to drug, traditional antihypertensive medications, then the suspicion for obstructive sleep apnea needs to be in the background, and that has to be ruled out as one of the contributing factors. Next slide. As you can see here, that as the degree of sleep apnea, the AHI is the apnea hypopnea index, that tells us what degree of sleep apnea someone has. So as the degree of sleep apnea increases, the odds ratio of someone developing hypertension and treatment-resistant hypertension also increases. Next slide. So in addition to cardiovascular issues like hypertension, heart failure, arrhythmias, having moderate to severe obstructive sleep apnea also increases cerebrovascular risk factors like TIAs, stroke, neurocognitive disorders, and also metabolic syndrome causing insulin resistance and diabetes. Next slide. So I want to touch upon a little bit about the common cardiovascular issues. In addition to increasing the risk of hypertension, very commonly you see patients that have new diagnosis of arrhythmias like atrial fibrillation, PVCs, which is premature ventricular complexes, tachycardia, bradycardia, where the heart rate is going high or low. When you have no other medical history, but you're having persistent issues with arrhythmias, which are hard to control, hypertension, which is hard to control, then the suspicion for obstructive sleep apnea needs to be, thought about and ruled out. This also increases the risk of cardiac issues like heart attacks and sudden nocturnal cardiac death. Next slide. In addition to cardiovascular neurological effects of obstructive sleep apnea also disrupts the quality of sleep and can cause poor concentration, impaired memory, increasing the risk of underlying mood disorders like anxiety and depression. Next slide. So now let's talk a little bit about the traditional treatment options and a little more about the newer alternative treatment options that are available. Lifestyle changes, including, dietary control, losing weight, optimizing good sleep with good sleep hygiene always is important. So broadly, the treatment options for obstructive sleep apnea can be categorized into non-surgical treatment options and surgical treatment options. Non-surgical would be the Cpap, the traditional BiPAP, oral appliances, which I will talk to you a little bit about in the next few slides. And Dr. Gomez will talk about focus on the surgical aspects for treatment of obstructive sleep apnea. Next slide. So CPAP is continuous positive airway pressure. So that is still considered as the gold standard and the treatment of choice for all degrees of sleep apnea, especially for moderate or severe. The reason why it is considered as a gold standard is because it not only stabilizes the sleep disordered breathing or sleep apnea, it improves the quality of sleep, improves the sleep efficiency, but also has shown to have a significant impact in decreasing the secondary issues related to obstructive sleep apnea by decreasing the risk of development of hypertension, heart disease, diabetes, arrhythmias, decreasing the risk of stroke and cognitive issues. Using the CPAP will need the patient to be adapted to using a mask, which is then connected to a machine. And with this treatment, all the machine is doing is blowing air at a certain pressure to keep the airways open. Next slide. So even though it is considered as the gold standard treatment, it comes with its own challenges. Many patients have issues with claustrophobia, not being able to tolerate having something on your face while you sleep, difficulty with excess air leakage that comes with the mask, swallowing air, leakage, bed partners experiencing sleep disturbance because of the noise from the machine, etc. Next slide. So the other treatment options that are available are mandibular advancing devices or oral appliances. Usually patients are seen by oral maxillofacial surgeons or dentists that have experience in treating patients that have obstructive sleep apnea. They're designed a specific oral appliance, which can be a tongue retaining device or a mandibular advancing device. And the goal with these oral appliances is to create more room in the back, help create excess room so that there is no crowding of your upper airway and help treat this obstructive sleep apnea. Mandibular advancing devices or oral appliances are primarily approved for patients who have mild obstructive sleep apnea on their diagnostic baseline sleep studies. Next slide. So coming to the surgical treatment options for obstructive sleep apnea, again, there are various available surgical options like uvulopalatopharyngoplasty, laser treatments, laser tongue reduction, nasal septal deviation correction surgeries, to more complex hyoid suspension mandibular advancement surgeries. It all depends on what degree of sleep apnea someone has and what their anatomy would allow the surgeon to figure out what is the best option for them. So I'm going to have Dr. Gomez take over the second half of this talk so that he can go over the surgical treatment options as well as the alternate newer treatment options for obstructive sleep apnea. Dr. Gomez?
Okay, very good. Can you hear me there?
Yes.
Okay, great. Well, thank you very much for putting this together. So, yeah, I think that Dr. Verma covered very well that initial part of what the sleep apnea is about, the medical management. So I just wanted to discuss some of this surgical option. And I think this is important because, you know, a lot of patients come to the office that they come to see me for different things and not necessarily for sleep apnea. But once I start asking them, not unusual, I have patients that tell me, well, actually I was on CPAP, I gave it a try, but I couldn't do it. So I left it alone and I'm not doing anything about it. So it is not unusual for some people to get really discouraged about it. And sometimes they don't even follow with a physician. And after that, they ignore the problem. So I think that I just wanted to talk about the surgical options to let people know that there's other possibilities. And also even on sleep, on the Cpap and BiPAP and all these other machines that are available, there's a lot of troubleshooting that can be done, whether surgical or just managing the pressures, etc. So Dr. Verma already discussed, these are some of the few surgical options that are available. And I did put here also tracheostomy, which is kind of the surgery that never you would like to have done for sleep apnea, but unfortunately, in some people who have really, really severe problems, maybe their only option. So as I was mentioning before, sometimes there are surgical procedures that can be done to improve tolerance to Cpap. So we know that fixing the nose in some people may help them improve Cpap tolerance, but we know sometimes patients come asking me if doing a septoplasty or something for the nose, is that going to cure their sleep apnea? And the answer is really not, but it may make the sleep apnea more tolerable, easier to manage. So septoplasty, turbinate reductions, nasal valve repairs are possibilities. Now, in regards to surgical options for sleep apnea, we have many options. And, at the beginning in surgery, a lot of times we try to figure out this surgical option didn't work very well. Let me try this other one, etc. So as you can see on this slide, the anatomy of the throat has different levels. And sometimes one level for one particular patient may be the most important to fix to get an improvement. For some people, maybe a different one. So, for example, on the roof of the mouth, one of the typical things that we used to do is what's called the UPPP. Probably a lot of you have heard about it or actually had it done. And the problem is that the success rate for a surgery like this by itself is really low. And the reason is, as I mentioned before, that there may be several levels of blockage. So sometimes you can do surgery on the side walls of the throat, and we call that pharyngoplasty, and that may help other type of people. So as you move further down, we have procedures for the tongue, we have procedures for the jaw, we even have procedures for the further cartilage that we have way down on the throat called the epiglottis. So the question here is, so how do we know what is a surgical procedure that will benefit the particular patient? And that is where the drug-induced sleep endoscopy comes. So the sleep study is done to know if someone has sleep apnea and to know the severity of the sleep apnea, the type of sleep apnea. But a sleep endoscopy is for people who we already know that they have sleep apnea, but we want to get further details of what exactly is getting blocked. So for example, in this case, I'm going to show you a patient that is having a blockage at the level of the roof of the mouth. What you're seeing on the lower part of the screen is the roof of the mouth. And on the upper part of the screen, you're seeing the back wall of the throat. And as you can imagine, this shouldn't be touching each other. This patient is trying to breathe and nothing is going through because it's completely blocked. So this patient particularly has a problem on the roof of the mouth. So this is a patient, for example, that you will think maybe a UPPP will be a good option. Then I'm going to show you another video. Now this one is going to be the back of the tongue that is actually the one blocking the throat. The back of the tongue is going against the back wall of the throat. And you can see that here in a moment. That's the tongue. This thing with the little dots is the tongue and is going against the back wall of the throat, and the patient is trying to breathe, nothing is going through. So, depending on what we see is getting blocked, we can determine what is the best surgical option. So We have newer procedures for the roof of the mouth. We don't do as much that UPPP, where we resect a lot of tissue. Instead of doing that, we like to preserve tissue by putting certain sutures in the roof of the mouth and the side walls to push things to the side and up and to the front to give more room. We also have some procedures for the tongue that are not done as frequently when the problem is a very bulky tongue. Obviously, as you can imagine, cutting on the tongue can be a very painful procedure. So we don't do this that often, but in some patients, this is necessary. We do have other procedures that are less invasive, such as some cutting on the front of the jaw, which although it sounds pretty invasive, actually is not as painful as the tongue procedures. And you rearrange certain areas of the jaw to push the tongue forward. We do have another procedure where we put sutures from a bone we have in the neck called the hyoid, which is above Adam's apple. And we tuck it to a suture, an anchor that we put on the jaw. And this suture kind of lifts that and improves the airway. Then we have upper airway stimulation, which is a stimulation directly on the nerve that pushes the tongue forward. And this procedure, there's one company only approved currently in the United States to do this, and is inspired for the people who haven't heard it. But essentially what you do is put a generator here that has the battery, and has a little wire that connects to a nerve on the neck. And when that nerve is stimulated, pushes the tongue forward. And there is a little lead that goes to a muscle of breathing. So it will detect when you're breathing and send the signal to that nerve. I'm going to show you that on this. This is a patient that has been already implanted. And when he goes to bed, this is what he does. He gets a remote control, passes it through next to the generator. And essentially what it does, as you can see on the video, it sends that electrical impulse that pushes the tongue forward. But as you can see here, it's also pushing the roof of the mouth forward. So it's acting at two different levels. With one single surgical procedure, you're fixing two different levels. And that's one of the benefits of this procedure over other surgical procedures. Now, this procedure, it used to be done with 3 incisions, one for the breathing sensor, another one for the generator, and a third one for the neck. Now we do it with 2 incisions only. So the incision on the chest serves the purpose of introducing the generator, and also the lead for the sensing breathing. So we only do it with 2 incisions now. This surgery is outpatient. You go home the same day, just with Tylenol and Motrin most of the time. And the battery lasts between 10 to 11 years. Usually you just come back 1 week after surgery to check on the wounds. And usually we let it rest for 4 to 6 weeks before we turn it on for the first time. So for those 4 to 6 weeks, you're not gonna have yet any treatment. Once you start the therapy, usually you start slowly. So we tend to say that this is more, it's not a race, it's more like a marathon. You have to take it slowly. And then eventually, a few months later, usually 3 months later, you get a sleep study to check the results of this. So what are the results of this? So this is one of the surgeries that has been studied the most in sleep apnea. And we do have already even the long-term data showing that it makes a significant difference. The reduction on the severity of sleep apnea is quite significant, as you can see on this slide. Also, the bed partner reported snoring. There is a significant improvement on that too. And the satisfaction rate is pretty good. One of the important aspects of this is that patient adherence with therapy is pretty good. As I was mentioning before, sometimes with Cpap, we just lose patients to follow up. And again, Cpap is still the first line therapy for this. And but my point is that it's easy for some people, for a certain group of people, it's easier to comply with a therapy when the only thing you have to do is put that, turn on that remote control. So again, it is very well studied. Nowadays tends to be approved by medical insurance much better than it was at the beginning. And basically to know if this is a procedure that is right for you. This is meant for people who have moderate to severe sleep apnea. And we measure that based on a number that Dr. Verma was discussing, that AHI. So, and then usually people have to have tried Cpap unless they have a major reason not to try Cpap, such as having severe claustrophobia, for example. But otherwise, you need to try Cpap first. And they have to have certain weight limitations. We usually go by what we call the body mass index, which is a measurement between the height and weight. And every insurance company is different, but in general, most of them are between 32 and 35 for that body mass index to be able to get approved for this procedure. And this sleep endoscopy that I was talking to is a must before we can perform this procedure. And it's only meant for adults so far. Now, before I finish, the sleep study, one of the important things with sleep studies is making sure also that the sleep study is relatively recent, right? So sometimes patients come with a sleep study that is 10 years old, and this is just a picture in time. Things change a lot. So sleep studies need to be done recently to make the best decisions. So in conclusion, sleep apnea is a very, very common problem in the United States. It is associated with a lot of medical problems and quality of life issues. And in fact, as you, I mean, I get patients referred by cardiologists, etc., because the patient has a hard to control hypertension, rhythm disturbances, and they cannot find other risk factor but the sleep apnea. There are multiple surgical alternatives to Cpap, and upper airway stimulation or hypoglossal nerve stimulation is one of them, but it's not the only one. And but it is a good therapy because it's acting at two different levels with a quick recovery, and we do have a lot of data supporting its use. And I think that at this point we're gonna open it for questions. Here's information for Dr. Verma and myself. I think with Dr. Verma, even through email, you can do appointments with me. You can either do it on the phone, and also we do have links on our website to make your own appointments. So yeah, I think at this point we're gonna open it for questions.
Great, thank you. Yes, please put any questions that you have in the chat window for either Dr. Verma or Dr. Gomez or both. One question I actually got via email, will Inspire help with snoring?
Yes. So one of the slides that I showed is that Beth partner reported snoring, and there's a very significant improvement on that.
Okay, excellent.
I agree to that. So it usually I tell patients that when you start the Inspire, so once the device gets activated in 4 to 6 weeks, then we give the patient a titrating protocol. Like every week you go up from this level to level 3 to level 4 to level 5. So usually what I do in the clinics after Dr. Gomez implants and sends the patient is, once the patient has been activated, then we have a 4-week follow-up appointment. We can do a virtual appointment just to see if the progression of the titration and the protocol has been going well. Then the next in-person appointment would be 6 weeks from the time of activation, so that we can check on the settings. And the snoring, that's one of the things that usually takes a little bit of time as they're going up on the levels of the settings and titrating the device upwards. Yes, the snoring can be eliminated then at that point.
Excellent. Another question, why is heated humidification preferred?
So heated humidification is mainly recommended for patient tolerance. It's not a requirement. It does not add or take away from the efficacy of the Cpap or a BiPAP or whatever positive airway pressure treatment. It is recommended so that, it eliminates the air being cold and prevents nasal dryness, dry mouth, those type of symptoms. So it's mainly patient preference. So they can use it. There are many patients that say, for example, in humid place like Houston right now, people are like, I don't need extra humidity added. So that's primarily for patient comfort.
Okay, thank you. Another question. A new method called Inspire is being advertised. What is your opinion of this?
Yeah, this is we didn't mention, I guess we didn't mention the name as frequently because what it is a hypoglossal nerve stimulator, but yeah, the only company that makes it is Inspire. So that's exactly the product that I was actually talking about. So, and yeah, my comment about it is exactly what we discussed. So it is a good therapy for a subgroup of people and with the benefit that it acts at 2 different levels. But it's not the only option. We do have other surgical options and not everyone is going to be a candidate for it.
Okay, excellent. I am going to wait just a moment for more questions to come in, and I'm going to also put in the chat window the contact information for both doctors. Let's see. Yes, this is what Dr. Gomez had shown on his slide. So feel free to contact us. Either of these numbers will get you to either of these doctors. And they're, in my personal humble opinion, I think they're great. And if you have any other questions, you could also email neuro.referrals@uth.tmc.edu, and I can route them that way too. So if there's no other questions, Elena, I'll hand it back over to you. Oh wait, we just got 2 more. Hang on. One question: why is it that as the older we get, the less sleep we get?
So the older we get, the average sleep requirement does not change. The sleep architecture, however, changes. What I mean by that is that we spend a lot more time in lighter stages of sleep as we get older, but the overall total sleep requirement is still the same, which is 7 to 8 hours. So if you feel like you're allocating 7 to 8 hours, you're sleeping 7 to 8 hours, but you're no longer waking up feeling rested, or if you have other symptoms of, sleep disruption like snoring, stopping to breathe, then chances are there is something else going on, i.e. a sleep disorder that is not diagnosed. That's the time where I would recommend seeking medical attention.
Okay, and one more. I'm currently a Cpap user, but my machine is wearing out. Wait time is 2 to 3 months. Should I discontinue its usage waiting for a machine?
So wait time to get a new machine or to see a physician?
I'm guessing that means to get a new machine, but
so I would not stop
to
treatment.
get a new machine.
To get a new machine. So I would not stop treatment with the existing machine unless there is a sleep study showing that there is no need to use the therapy. So I would work with their sleep medicine provider and the company that the provider has referred them to see if they can expedite the patient getting the machine.
Okay. And of course, always ask your current doctor to make sure, since we're not looking at your records or anything. One more question. The question says dual therapy. I guess, can you do an oral appliance with Cpap?
Yes, you can. So again, all under medical supervision. There are certain patients that use an oral appliance for bruxism, which is teeth grinding, or oral appliance specifically for treatment of sleep apnea. So there are patients where the oral appliance will treat part of the sleep apnea if designed correctly by the right oral maxillofacial surgeon or a dentist. So that will treat part of the sleep apnea so that the need for higher Cpap pressures and stuff can be eliminated.
Okay, and the questions keep coming. I understand that melatonin production decreases with age. How do you feel about supplementing with oral melatonin?
So my melatonin out of all the sleep aids is the more gentler form of sleep aid, but primarily it only affects sleep onset. It has no usual effect on sleep maintenance part. So if you do not have underlying issues with insomnia, where you're difficulty falling asleep, maintaining sleep, you do not have to supplement any sleep aid, nor prescription sleep aid, nor even melatonin. But if you're having those issues and having those issues on a more persistent basis, more than 2 to 3 times per week, chances are there is an underlying issue, whether it's a sleep disorder or a mood disorder like anxiety, depression, stress that is contributing to the insomnia. So I would recommend talking to a sleep medicine provider or your physician, trying to figure out what is the cause of the insomnia rather than just using a supplement.
Okay, that is great. With that, we can wrap up. So Elena, I'll hand it over to you now. Thank you.
Great, that's great. I know sometimes we think and then have another question. This has been an excellent presentation, and I know that everybody has learned quite a bit from Dr. Verma and Dr. Rivera. And again, I will be sending out the recording that does include the PowerPoint. Please continue to stay with us. Again, once a month, we thank UT Health Houston for their support and for providing all these wonderful ways for us to engage and stay healthy. And I only wish the best for everybody in good health and to have a good rest of the day. Bye-bye now.
Thank you.
Thank you very much.